Okay, so this gets us to the next question, that is question 81. Just give me one sec. Okay, so this gets us to question 81. Question 81, which says a 48-year-old woman has lymphosarcoma involving lymph nodes. Over the next 2 months, lymphoma decreases on CT because of chemotherapy. So, which mechanism responded to chemotherapy? And the answer is T, that is apoptosis. So, the cell death that is taking place, because of chemotherapy, it is mediated by apoptosis, plain and simple. Whereas phagocytosis, this is a leukocyte which is phagocytosing a microbe. Mitochondrial poisoning, no. And this is of course not coagulative necrosis. Coagulative necrosis is mediated by ischemia. Next, 82. A 56-year-old has chest pain, coronary angiogram more than 90% inclusion. In this setting, irreversible injury has occurred. So, which of the following changes would occur? That is, answer is C. Nuclei undergo chemoraxis. The nuclei, by mistake, let me write it properly. The nuclei, they undergo karyorrhexis. So, this is an irreversible change. Whereas depletion of glycogen stores, sodium increase or pH reduction, all these are reversible in nature. Decreased glycogen, increased sodium or reduced pH, they are reversible. Irreversible changes, nuclei which undergoes karyorrhexis. So the answer is C. Next, coming to the next one, that is question 83. Early phagocytosis of dead cells by macrophages, what time period? 3 to 7 days. This is extremely important. See, let us see the pattern of light microscopic changes in ischemic heart disease. The pattern of light microscopic changes in ischemic heart disease. The first change that we see is waviness of fibers. This is followed by neutrophilic infiltration. And necrosis of cardiac muscle. Neutrophilic infiltration and necrosis, which is followed by, now the healing starts. Pehle waviness of fibers, neutrophilic infiltration and necrosis. These were the damaging causes. Now healing starts. So macrophage activation and phagocytosis. Macrophage activation and phagocytosis. Next, early granulation tissue formation. Early granulation tissue formation followed by scarring. Followed by scarring. So this is the pattern of light microscopic changes: waviness of fibers, neutrophilic infiltration and necrosis, macrophage activation and phagocytosis, early granulation tissue formation, scarring. Let us have a look at time periods. First change was waviness of fibers. Time period half an hour. Half an hour to 4 hours. Next, neutrophilic infiltration and necrosis, 1 to 3 days. Next, macrophage activation and phagocytosis, 3 to 7 days. Early granulation tissue formation, 7 to 10 days. Scarring, more than 2 weeks. Scarring, more than 2 weeks. So, these are the pattern of light microscopic changes in ischemic heart disease. The question was on macrophages at infarct borders, that is 3 to 7 days. Next. Next, question 84. Question 84. Question 84, it says false regarding Bernard-Sollier syndrome. Large platelets, they are seen. Decreased platelet count, that is also seen. Ristocetin aggregation normal, this is false. Ristocetin aggregation normal, this is false. In Bernard-Sollier syndrome, the platelet aggregation studies, what we do in platelet aggregation studies is we expose the platelets to ADP, collagen and ristocetin. We expose the platelets to ADP, collagen and ristocetin. If the response to ADP is normal, to collagen is normal, whereas to ristocetin is abnormal, then the disease is Bernard-Sollier syndrome. So, in Bernard-Sollier syndrome, the response to ristocetin aggregation is abnormal. It's not normal. Whereas the other way around, reduced response to ATP, reduced to collagen, whereas normal to ristocetin. This is Glanzmann's thromboasthenia. This is Glanzmann's thromboasthenia. So, they have opposite responses. ADP, collagen, ristocetin, Bernard-Sollier and Glanzmann's thromboasthenia. Next. This gets us to the next question, that is question 85. Most commonly seen antibody in antiphospholipid antibody syndrome. It is anti-beta-2 glycoprotein antibody. Anti-beta-2 glycoprotein antibody. The most commonly seen antibody in antiphospholipid antibody syndrome is anti-beta-2 glycoprotein antibody. Other antibodies that are seen are anti-cardiolipin antibody. It is APLA, that is lupus. It is also associated with anti-cardiolipin antibody and lupus anticoagulant and lupus anticoagulant. This is question 85. Next, question 86. Which is not an autoimmune disease? Myasthenia gravis, it is autoimmune. Next, SLE is autoimmune. Graves is autoimmune. So the answer is sickle cell disease. You very well know sickle cell disease, it is a hemoglobinopathy. Sickle cell disease, it is a hemoglobinopathy associated with a point mutation in the 6th codon of beta chain. It is a hemoglobinopathy associated with the point mutation in the 6th codon of the beta chain. It is not a autoimmune disease. This is sickle cell disease. Next, this gets us to the next one, that is question 87. Question 87. 29-year man, desert safari, dark complexion. Which contributes the most? Tyrosine. Answer is C. That is, it is mediated by tyrosine. Why? Because this is the tanning process in skin which is taking place. This is the tanning process which is taking place in the skin. So melanocytes, they have the enzyme tyrosinase. Melanocytes, they have the enzyme tyrosinase. This tyrosinase enzyme, it converts tyrosine to melanin in the melanin production pathway. So the stuff that is responsible for tanning is tyrosine. Next, 88. Study was performed to identify predisposing factors. Epithelial metaplasia, in which of the following is most likely to take place? Vitamin A deficiency. Vitamin A deficiency. So let us have a look at this. Now, metaplasia, it is of two types. Epithelial metaplasia. Firstly, what do I mean by metaplasia? Metaplasia is one lining which is changing into another. Metaplasia, it is of two types. Epithelial metaplasia and connective tissue metaplasia. Epithelial metaplasia, it is again of two main types. Squamous metaplasia and columnar metaplasia. Epithelial is again of two main types, squamous and columnar. Which is more common? Squamous metaplasia. Next point, the main risk factors for squamous metaplasia are smoking and vitamin A deficiencies. Smoking and vitamin A deficiencies. These are the main risk factors for squamous metaplasia. Whereas columnar metaplasia, this is Barrett's esophagus, associated with GERD, gastroesophageal reflux disease. Next, This gets us to the next one, that is question 89. Question 89. Lifestyle pattern, healthy persons 20 to 30, pizza visa, they are having more pizza, so what would be seen? It would be associated with hypertrophy of steatocytes. Hypertrophy of steatocytes. Because I need not tell you this, you already know it. If a person is having more junk food or more pizza, the steatocytes or the fat cells, they undergo hypertrophy, they increase in size. It's not fatty morphosis of the liver. Pancreatic fat necrosis, no, not at least by pizza. You can get it by alcohol consumption. Fatty degeneration of the myocardium, no. So the answer is hypertrophy of the steatocytes. This is the one that is associated with obesity. Associated with obesity. Next, 90. Chronic smoker, recurrent fever and stuff. Which cancer is the patient suffering from? Answer is D, that is small cell carcinoma. Small cell carcinoma. How? So let us see a few points with lung tumors. The first lung tumor is squamous cell carcinoma. Squamous cell carcinoma. First point, it is the most common carcinoma in India. We're talking about lungs, so it is the most common lung cancer in India. Next point, it is commonly central in location. It is commonly central in location. Next point, microscopically, it is associated with the presence of keratin pearls. Squamous cell carcinoma, most common cancer, lung cancer in India, central in location, microscopically associated with keratin pearls. Next point, it is associated with smoking. It is associated with smoking. But coming to the next tumor, that is small cell carcinoma lung. Coming to the next one, that is small cell carcinoma. This firstly has the strongest association with smoking. This has the strongest association with smoking. So with smoking, the strongest association is with small cell, followed by squamous cell carcinoma. Next point, microscopically it shows two features. Nuclear molding. It shows two features, nuclear molding and Azzopardi effect. So small cell carcinoma lung, microscopically it shows two features, nuclear molding and Azzopardi effect. So the answer to the question is small cell carcinoma lung. Next. This gets us to the next question, that is question 91. All may contribute to this, all may contribute to free radical except glutathione peroxidase. Except glutathione peroxidase. Absolutely nothing to explain in this. You very well know that glutathione peroxidase, it is an antioxidant. It is an antioxidant. Intracellular killing. Superoxide dismutase is also an antioxidant, but thing is, oxygen is converted by NADPH oxidase to O2 minus, that is to superoxide anion. This superoxide anion is acted upon by superoxide dismutase to form H2O2, hydrogen peroxide, which in turn is acted upon by myeloperoxidase and chloride to form hypochlorous anion. This is the pathway of killing. So superoxide dismutase is playing a role. Fenton's reaction, it obviously produces free radicals. NADPH oxidase or the phagocyte oxidase pathway is the main step. So answer is glutathione peroxidase. It is an antioxidant. Next. This gets us to the next question, that is question 93. Oh, I think I skipped one. Question 92. My mistake. Question 92. Which of the following are responsible for oxygen burst? We have just seen the whole pathway. We have just written the whole pathway. So oxygen burst, it is mediated by oxidase, which is your option C, oxidase. Next, this gets us to question 93. First, have a look at the image. What the image is showing you is the presence of large cells. It shows the presence of large cells with an eccentric nucleus and abundant cytoplasm. So have a look at the image. The cells which are seen are large cells, eccentric nucleus, abundant cytoplasm. These are the plasma cells. So it is a diagnosis of multiple myeloma. So question 93, it is a diagnosis of multiple myeloma. First point. Next, now you know it is multiple myeloma. So which is most likely present? Answer, hypergammaglobulinemia. So the answer to question 93 is hypergammaglobulinemia. Because the gamma globulins, they are elevated in multiple myeloma. Hypergammaglobulinemia seen in multiple myeloma. You very well know most common immunoglobulin in multiple myeloma is IgG. Next, question 94. Question 94. Firstly, have a look at the image. What the peripheral smear is showing you is the presence of sickle cells, making it sickle cell anemia. It is showing you the presence of sickle cells. So now it is easy. Sickle cell anemia, it is a hemolytic anemia. It is a hemolytic anemia. So it is associated with the presence of pigmented gallstones. So it is associated with the presence of pigmented gallstones. All you had to do in this question was to recognize the image as that of sickle cell anemia. You are seeing the presence of beautiful sickle shaped RBCs. This is a sickle shaped RBC in the peripheral smear. Next. Question 95. First, identify the organ. The organ is liver. First point. Whenever you see any image based question, I'm again repeating this, what will make or break you? I'll write this for you. What will make or break you are the images. Are the images. Extremely important. So whenever you have a live class in pathology, make sure that your pathology teacher is showing you close to 200 to 250 images in the class. I take a 3 to 4 day class and I show at least 300 images. Out of those 300, if you don't see 300 images, you will not be able to attempt 8 to 9 images which come in the paper. Around 12 images come in the paper, out of which to attempt 8-9 you need to see more number of images. So MCQs, theory, everything is okay. Images, they cannot be explained very well in the satellite. For that you need a live class. So what will make or break you are the images. Extremely important. Extremely important. So in this question, first identify the organ. Organ is liver. Next, it is showing you a fatty liver disease or steatosis. It is showing you a fatty liver disease or steatosis. So now the answer is easy. That is alcoholism. Fatty liver disease, stage 1, alcoholism. Next, this gets us to the next question, that is question 96. Question 96. Again, first recognize the organ. Organ is liver. Recognize the presence of hepatocytes. Liver. Showing hemosiderin deposition. I don't even need to look at the question to solve this. This is hemosiderin deposits in liver. This is hemosiderin in the liver. Organ is liver. For this, you need to have a look at normal and a various set of liver microscopies. Those of you who have had my class, they will find it very easy, but you need to have a look at them. Next, this gets us to the next one, that is 97. Question 97. The histology in neuroblastoma. It is again showing you the presence of Homer-Wright pseudorosettes. These are the Homer-Wright pseudorosettes seen in neuroblastoma. Homer-Wright pseudorosettes. See, first point, what is a true rosette? A true rosette, it has a central lumen. I'm not saying it is a blood vessel, it is a central lumen. Anything other than a central lumen is a pseudorosette or a false rosette. So, in neuroblastoma, you have the presence of Homer-Wright pseudorosettes with a central neuropil. In neuroblastoma, you have Homer-Wright pseudorosettes with a central neuropil. So what you see is a rosette of cells. What you see is a rosette of cells with a central neuropil. With a central neuropil. This is the classical image of neuroblastoma showing Homer-Wright pseudorosettes. Next, question 98. Question 98. In 98, again recognize the parent organ first. The organ that you have in this is the liver. Showing the presence of the arrow is an apoptotic hepatocyte. What you see here is an apoptotic shrunken hepatocyte, which is called as a councilman body. So the answer is councilman body. You have the presence of apoptotic hepatocytes, making it councilman bodies. Next, coming to the next one, that is question 99. Question 99. Spleen showing wedge-shaped infarcts. Spleen showing wedge-shaped infarcts. This is the gross of spleen showing wedge-shaped infarcts. How are the infarcts looking like? They are the pale areas. Infarcts, they are the pale areas that we are seeing in spleen. So answer is infarction. Answer is okay. This gets us to the next one, that is 100. Question 100. Again, aggregates of tau protein. So firstly, it is telling you that it is tau protein, Alzheimer's, showing the presence of neurofibrillary tangles. So the answer is C. What you see here are the neurofibrillary tangles. Neurofibrillary tangles. These neurofibrillary tangles, they are aggregates of tau protein. They are the aggregates of tau protein, and what they look like are these tail-shaped cells. They are looking like these tail-shaped cells. Tail-shaped cells, which are the neurofibrillary tangles. Done. Okay, so this gets us to the next question. That is question 101. Question 101. Ovarian cell follicles. The classical thing that we are seeing here is the presence of Kohl-Exner bodies. This is a microscopy of Kohl-Exner bodies seen in granulosa cell tumors. Kohl-Exner bodies, granulosa cell tumors. So what do you see? A classical Kohl-Exner body. You see the presence of large eosinophilic inclusions. You see large eosinophilic areas with presence of tumor cells all around. With presence of tumor cells all around. So the black cells are the tumor cells and these are the large eosinophilic structures. Kohl-Exner. It looks like a primitive telephone. You pick the receiver and you dial from the center. Kohl-Exner bodies, granulosa cell tumors. So this is granulosa cell tumor, Kohl-Exner bodies. Next, coming to the next question, that is question 102. Question 102. This is again a spotter. Question 102. Eosinophilic intracytoplasmic inclusions. What you are seeing here is the presence of Rosenthal fibers. Rosenthal fibers seen in pilocytic astrocytoma. Seen in pilocytic astrocytoma. So these are the Rosenthal fibers, pilocytic astrocytoma. Next, coming to the next one. That is question 103. Stain shown in illustration. It is most likely to show this is the nigrosin stain. This is the nigrosin stain which is used for E. coli. Nigrosin stain which is used for E. coli. Next, it is for negative staining of bacteria. Nigrosin stain, it is used for negative staining of bacteria and capsulated fungi. It is used for negative staining of bacteria and capsulated fungi. Nigrosin stain. Next, question 104. Question 104. What it shows you, the skin biopsy is there. What you have is the basal layer of keratinocytes is intact. The basal layer of keratinocytes is intact, whereas there is loss of intercellular connections in between. With loss of intercellular connections. With loss of intercellular connections. That is why the area what you have are the basal layer of epithelial cells. Then there is a lot of white space. That is the loss of intercellular connections, which is taking place in suprabasal cells. This loss of intercellular connections, it is taking place in suprabasal cells. Next, what you have in question 105. Question 105. This is the classical appearance of a rhabdomyoblast. Question 105. What you are seeing, even with an arrow on it, is a rhabdomyoblast. It is an elongated spindle cell. Rhabdomyoblasts, they are elongated cells. They are the elongated cells. So the answer is C, that is rhabdomyosarcoma. Answer is C, that is rhabdomyosarcoma. Next, question 106. Question 106. Marker for teratoma. This is a sacrococcygeal teratoma. You can clearly make out it is a teratoma which is seen in sacrococcygeal region. So this is a sacrococcygeal teratoma. A sacrococcygeal teratoma. And sacrococcygeal teratoma, it shows two main markers. AFP, that is alpha fetoprotein. It shows two markers. AFP, that is alpha fetoprotein, and HCG. So the answer to question 106 is option B, that is beta HCG. That is beta HCG. Next, question 107. Question 107. Identify the cell in rheumatic heart disease. The examiner told you everything by even mentioning rheumatic heart disease. You very well know the pathognomic feature of RHD. Pathognomic feature of RHD is the presence of Aschoff bodies. Pathognomic feature of RHD is Aschoff body, whereas the pathognomic cell in RHD is the Antishkov cell. The pathognomic cell is the Antishkov cell, also called as caterpillar cell. Also called as caterpillar cell. So the pathognomic cell is the Antishkov cell or the caterpillar cell. So what you have here, what you have in the microscopy is answer C, that is Antishkov cell. It is the pathognomic cell of RHD, caterpillar-like nucleus. Next point. Coming to the next image, that is question 108. Question 108. First, identify the microscopy. First of all, identify the image. You have thyroid showing medullary carcinoma thyroid. What you have here are sheets of tumor cells. You see the presence of sheets of tumor cells with amyloid. With amyloid. You very well know amyloid deposition is seen in medullary carcinoma thyroid. Which protein is getting deposited in medullary carcinoma thyroid? It is ACAL protein. Medullary carcinoma thyroid, it is associated with the deposition of acal protein. Next point. So now if you know that it is medullary carcinoma thyroid, now the answer is easier. Total thyroidectomy. Total thyroidectomy. Just give me 1 sec on this. Okay, sorry. So once you know that the diagnosis is medullary carcinoma thyroid, then the answer is obvious. That is D, total thyroidectomy. Total thyroidectomy. So the main thing in the question is recognizing the image as medullary carcinoma thyroid. Next, question 109. Question 109. First point. 60. Let's see the hints to the question. The answer is C, xanthogranulomatous pyelonephritis. Answer is C, that is xanthogranulomatous pyelonephritis. Let us see the hints to the answer. What you have is a 65-year-old male, that is an elderly male with enlarged left kidney. Nephrectomy showed yellow appearing lesion, so it is fat. Yellow appearing lesion. It showed a yellow appearing lesion with lipid laden foamy macrophages. With lipid laden foamy macrophages. So with these options, elderly, yellow appearing lesion, lipid laden foamy macrophages, the answer is obvious, that is, it is a xanthogranulomatous pyelonephritis. This xanthogranulomatous pyelonephritis, it is associated with E. coli and Proteus infections. It is associated with E. coli and Proteus infections. Next. Question 110. Question 110. Following images represent which one is the wrong match? Answer is C, that is a vitelline polyp. It is not a vitelline polyp. C, the figure C, it is Meckel's diverticulum. Figure C, it is Meckel's diverticulum. Let us have a look at others. The first is a vitelline duct cyst. You know vitelline duct, it connects gut to the yolk sac. It connects gut to yolk sac. This is vitelline duct. It connects the gut to the yolk sac. So, In the first option, you have a cyst in the vitelline duct. That's okay. In the second, it is leading to a sinus formation and is draining onto the umbilicus. Fourth is a vitelline band. So A, B and D are matching, whereas C is Meckel's diverticulum. And you very well know Meckel's diverticulum, it follows rules of two. Meckel's diverticulum, it follows the rules of two, and the main rules of two are how long? It is 2 inches long. 2 inches long. Next, it is 2 feet from ileocecal junction. It is 2 feet from ileocecal junction. Next, it is seen in 2% of the population. 2% population. Next, twice more common in males than females. Twice more common in males than females. And symptomatic by 2 years in 4% patients. It is symptomatic by the age of 2 years in 4% of the patients. This is Meckel's diverticulum. Next, question 111. Question 111. All are true about xanthogranulomatous inflammation associated with TB? No. All are true except associated with TB. You very well know foam cells are present, yellow nodules are present, and multinucleated giant cells are also seen. Next, it also shows the presence of foamy macrophages. It also shows the presence of foamy macrophages. It is not associated with TB. The infections that are seen are E. coli and Proteus. Xanthogranulomatous pyelonephritis. But xanthogranulomatous inflammation, it is associated with E. coli and Proteus. Next. This gets us to the next question, that is question 112. Question 112. All are true about coagulation pathway except intrinsic pathway can be activated by in vitro. Fair enough. Calcium is necessary for several steps. That is also true. Factor 10 is important in both intrinsic and extrinsic. True, because you have the extrinsic pathway and the intrinsic pathway which come together onto the common pathway. And the first step in common pathway is conversion of factor 10 to 10A. Conversion of factor 10 to 10A, which is mediated by calcium phospholipids, and phospholipids along with factor 5. This is 10 to 10A conversion. So, factor 10 is important in both extrinsic and intrinsic pathway. So, all are true except extrinsic pathways via contact negatively charged surfaces. No. Answer to question 112 is D. Extrinsic pathway is not via negatively charged surfaces. Extrinsic pathway, this is activated by tissue factor. Extrinsic pathway, it is activated by tissue factor. So the answer to question 112 is D. Intrinsic pathway is by negatively charged surfaces. Intrinsic pathway is by negatively charged surfaces. So answer is D. Next, this gets us to the next question. This gets us to the next question, that is question 113. HBH disease. Answer: deletion of 3 alpha chains. Deletion of 3 alpha chains. This again has been repeatedly asked. So let us see the genotype-phenotype correlation. Genotype-phenotype correlation in alpha thalassemia. Genotype-phenotype correlation. Genotype is the genetic structure, phenotype are the clinical features. Normally there are 4 alpha chains. All of us, we have 4 alpha chains. So the genotype is alpha, 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 alpha. This is normal. Next point, deletion of 1 alpha chain. Deletion of 1 alpha chain. Genotype क्या होगा? 1 alpha chain is deleted. So 1 alpha is gone, minus alpha, alpha, alpha. This is an asymptomatic carrier state. This is an asymptomatic carrier state. Deletion of 1 alpha chain. Next, deletion of 2 alpha chains. Deletion of 2 alpha chains. क्या जीनोटाइप होगा? 2 चेन डिलीटेड है, माइनस माइनस अल्फा अल्फा. This presents as thal minor. This presents as thal minor. Next, deletion of 3 alpha chains. What would be the genotype? Minus 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 alpha. This presents as HBH disease. This was the question. Whereas deletion of 4 alpha chains, all the 4 are deleted, minus 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 minus. This is Hydrops fetalis. Hydrops fetalis, which is lethal in utero if transfusions are not given. So, genotype-phenotype correlation in alpha thalassemia, deletion of 1 chain, asymptomatic carrier state, 2 chains, thal minor, 3 chains, HBH disease, 4 chains, Hydrops fetalis, which is lethal in utero. Next. Question 114. Now, we have already seen this. Squamous metaplasia takes place because of irritant effect of smoking. We have already seen this in the metaplasia question. Squamous metaplasia was of 2 types, epithelial, connective tissue. Epithelial metaplasia, more common was squamous metaplasia. Squamous metaplasia, most common organ was lung. Now, what is the predisposing factor? Smoking. Why? Because smoking has an irritant effect on respiratory linings. It has an irritant effect on respiratory linings, in turn leading to squamous metaplasia. in turn leading to squamous metaplasia. So this is question 114. Next, 115. Question 115. A 19-year-old sick G2P1 woman, amniocentesis. Now point is cells were subcultured and culture is lost after 50 doublings. 50 doublings, it is a normal lifespan. So which phenomena is it showing? It is demonstrating aging. They were not the stem cells. Stem cells, they have limitless replicative potential, but here these were the fibroblasts, or they were the somatic cells, that is fibroblasts. They have a normal replicative potential of about 50 doublings, which is showing aging. Why? Because of telomere shortening, free radical induced injury, and the various other steps that we have seen with aging. Next, question 116. Chronic graft rejection, most common pathway. Answer is A, that is type 4 hypersensitivity. Chronic graft rejection, type 4 hypersensitivity. So graft rejection, it is of three main types. Hyperacute graft rejection, acute graft rejection, and chronic graft rejection. So graft rejection, it is of three types: hyperacute, acute, chronic. Hyperacute graft rejection, this takes place because of preformed antibodies. Against donor. Preformed antibodies against donor. Next point, which type of hypersensitivity is this? This is type 2 hypersensitivity reaction. Hyperacute, type 2 hypersensitivity. Acute graft rejection, it is of two types. It can either be a cellular graft rejection or a humoral graft rejection. Hyperacute was type 2 hypersensitivity. Acute, it is of two types: cellular or humoral. Cellular graft rejection, it is mediated by cells. So this is type 4 hypersensitivity, whereas humoral is mediated by antibodies, that is type 2 hypersensitivity. Type 2 being more common. Whereas in chronic graft rejection, it is mainly mediated by cells. So the main hypersensitivity reaction in chronic graft rejection is type 4 hypersensitivity. So answer to the question is type 4 hypersensitivity reaction. Next point. Coming to the next question. One seven. Alports. It is a mutation in collagen type 4. You very well know Alport syndrome. It occurs because of a alpha chain mutation. Alport syndrome, it occurs because of an alpha 5 chain mutation in collagen type 4. Next, two important questions that are asked with Alports. The next two questions that are asked with Alports are the diagnostic hallmark. The diagnostic hallmark of Alport syndrome is splitting of lamina densa. Splitting of lamina densa, giving it the classical basket weave appearance. Giving it the classical basket weave appearance. So the diagnostic hallmark of Alport's is splitting of lamina densa, giving it basket weave appearance. Next point, the most common symptom of Alport's is sensory neural hearing loss. Most common symptom, sensory neural hearing loss. Seen in what percentage of patients? Seen in around 60% of the patients. So, Alport syndrome, it is a mutation in collagen type 4, alpha 5 chain mutation. Diagnostic hallmark, splitting of lamina densa, basket weave appearance. Most common symptom, sensory neural hearing loss. Next. Question 118. Question 118. Which of the following is specific for chest? Answer A. CD 117. Now let us see few points with GIST. GIST, it stands for gastrointestinal stromal tumor. Gastrointestinal stromal tumor. It is a stromal tumor, that means it is a mesenchymal tumor. It is a mesenchymal tumor. So, first point, it is the most common mesenchymal tumor of abdomen. GIST, it is the most common mesenchymal tumor of abdomen. Next point, most common site, stomach. Most common site, stomach. Next, cell of origin, interstitial cells of Kajal. Cell of origin, interstitial cells of Kajal. Next point, most sensitive marker or the most common marker, CD117. Most specific marker, DOG1. So most sensitive or the most common marker, CD117. Most specific, DOG1. DOG1 stands for designed for just one marker. DOG1, that is designed for just one marker. Most specific. Done. Next, question 119. All are true about hairy cell leukemia except, this is extremely easy, answer is B. They result from expansion of neoplastic T lymphocytes. They are not T lymphocytes. This is wrong. Hairy cell leukemia, it arises from B lymphocytes. It arises from B lymphocytes, not T. Firstly. Second, you very well know the splenomegaly is conspicuous. It is seen. Cells are positive for TRAP and they are CD25 positive. So answer is B. That is, they do not arise from T lymphocytes. Next is question 120. Serum C3, it is low in PSGN. post-streptococcal glomerulonephritis. It is associated with hypocomplementemia. It is associated with hypocomplementemia, that is low serum C3 levels. But point to be noted here is this hypocomplementemia, it is transient in nature. It is transient in nature and gets corrected within 6 to 8 weeks or 2 to 3 months. This hypocomplementemia, it is transient in nature and gets corrected within 6 to 8 weeks or 2 to 3 months. Next point, PSGN, immunofluorescence, starry sky appearance. This you already know. Immunofluorescence with PSGN, it shows the classical starry sky appearance. This is asked. Next point, site of deposit. PSGN, the site of deposit, it has a subepithelial deposit. It has a subepithelial deposit. Next, this subepithelial deposit which is seen in PSGN, it has a special name to it called as humps. Next, which is the most important complement? First common point between classical and alternate, C3. Question 121, answer is A, C3. See, there are three pathways. The classical pathway, which starts with C1, goes to C3, C5 and then to membrane attack complex. This is the classical pathway. Starts with C1, C3, C5 and membrane attack complex. Membrane attack complex is C5 to C9. Then there are the alternative pathway and mannose-lectin binding pathway. Alternative and mannose-lectin binding pathway. Both of these, they converge directly on C3. So the first contact point or the first common point is C3. Next, question 122. BCL2, it is follicular cell lymphoma. BCL2, follicular cell lymphoma. Easy. There are three BCL protein expressions that are asked. BCL1, mantle cell lymphoma. BCL1, mantle cell lymphoma. BCL2, follicular lymphoma. Whereas BCL6, DLBCL. DLBCL stands for diffuse large B cell lymphoma. Diffuse large B cell lymphoma. So, BCL1, mantle cell lymphoma. BCL2, follicular lymphoma. BCL6, DLBCL, diffuse large B cell lymphoma. Next, this gets us to the next question, that is 123. Question 123, least likely to be accompanied by lymphocytosis. See, bacterial infections answer is C, that is bacterial infections. Bacterial infections, they are associated with neutrophilia, that is increased number of neutrophils, not lymphocytosis. So answer is bacterial infections. Next, question 124. Question 124. Which of the following is a good outcome in neuroblastoma? Let us go point wise. Diploidy, poor prognosis. N-MYC amplification, poor prognosis. Chromosome deletions, poor prognosis. TRK expression, good prognosis. So the answer is D, that is TRK expression. This is associated with good prognosis. Whereas TRK expression, this has to be remembered. TRK expression is associated with good prognosis, whereas TRK expression is poor prognosis. TRK expression is poor prognosis. Next point with respect to diploides. Hyperdiploidy is good prognosis. Hyper, that is increase in the number of chromosomes, is good prognosis, whereas diploidy is poor prognosis. Next. Question 125. Which gene defect is associated with medullary carcinoma thyroid? Medullary carcinoma thyroid, answer is A, that is ret proton gene mutation. Why? Because medullary carcinoma thyroid, it is a part of MEN syndromes. Which MEN? MEN2 syndrome. It is a part of MEN2 syndrome, and MEN2 syndrome, it is associated with ret proton gene mutations. This ret proton gene, it is present on chromosome 10. This again is asked. Ret proton gene, it is present on chromosome 10. Next. Question 126. We have already seen this. Elevations of unconjugated bilirubin. So, genetic cause of unconjugated hyperbilirubinemia are Crigler-Najjar type 1, Crigler-Najjar type 2 and Gilbert's. We have already discussed this in the previous question. So, answer is B, that is Crigler-Najjar syndrome. That is Crigler-Najjar syndromes, because you very well know unconjugated hyperbilirubinemia is Crigler-Najjar syndromes type 1 and type 2 along with Gilbert's syndrome. You know this. Unconjugated hyperbilirubinemia, Crigler-Najjar type 1, type 2 and Gilbert's. Whereas conjugated hyperbilirubinemia, the genetic disorders are Dubin-Johnson syndrome and Roter's syndrome. So conjugated are Dubin-Johnson and Roter's syndrome. Next. Question 127. Question 127. which causes both intra and extravascular hemolysis? And the answer is A, that is G6PD deficiency. G6PD deficiency, it most commonly causes extravascular hemolysis. It most commonly causes extravascular hemolysis, and the main site of hemolysis is spleen. G6PD deficiency most commonly causes extravascular hemolysis, and the main site is spleen, whereas it can also have a minor component of intravascular hemolysis if damage to RBCs is extensive. If damage to RBCs is extensive. So answer is G6PD deficiency. Next. Question 128. Characteristic feature in kidney from HUS. It is a thrombotic microangiopathy. It is a thrombotic microangiopathy. What do I mean by this? See, HUS, it comes under MAHA. MAHA, it stands for microangiopathic hemolytic anemias. Microangiopathic hemolytic anemia. So, the main causes of microangiopathic hemolytic anemias are DIC, that is disseminated intravascular coagulation, HUS, hemolytic uremic syndrome, TTP, thrombotic thrombocytopenic purpura. DIC, HUS, TTP, these are the main causes of MAHA. Another causes HELP syndrome. Hemolytic anemia, elevated liver enzymes, low platelets. HELP syndrome. And another causes complement factor B and H deficiencies. Complement factor B and H deficiencies. So the question is asking about characteristic feature of hemolytic uremic syndrome, HUS, thrombotic microangiopathy, because it is a component of MAHA. Next, question 129. Question 129. We have discussed this extensively. Genomic imprinting, Prader-Willi and Angelman syndrome. So differential expression of same gene depending on parent of origin is genomic imprinting. We have discussed this in detail in the previous question when we discussed Prader-Willi, Angelman and disomies. Next, question 130. Question number 130. To which of the following do lipoxins belong? This is again extremely easy. It is an arachidonic acid metabolite. It is an arachidonic acid metabolite. Arachidonic acid metabolism, there are 4 pathways, but the 2 main ones are cyclooxygenase, lipoxygenase. So, the lipoxygenase pathway, it produces leukotriene B4, leukotriene C4, D4, E4 and lipoxins. So the lipoxygenase pathway It produces leukotriene B4, leukotriene C4, D4, E4 and lipoxins. So lipoxins, they belong to arachidonic acid metabolites. Next, question 131. Which is anti-apoptotic? Anti-apoptotic is BCl2. Which of the following is anti-apoptotic? BCl2. The other anti-apoptotic genes, are BCl2, this you already know, and BClXL. BCl2 and BClXL. Whereas pro-apoptotic, they are bad Bax and BIM. The pro-apoptotic genes are bad Bax and BIM. This is, so the answer, anti-apoptotic, BCl2. Next. Next, question 132. Question number 132. Which of the following is true regarding Western blot? Answer for Western blotting. I think we have skipped a question. We are done with question 131, anti-apoptotic. Next, answer with respect to Western blotting. It is gel electrophoresis of proteins. Gel electrophoresis of proteins. Easy to remember. Southern blotting is for DNA. Southern blotting is for DNA, whereas northern blotting is for RNA. Southern blotting DNA, northern blotting RNA, western blotting proteins. Next. Question 133. Endothelial molecule involved in transmigration of cells. This is a factual question, and the endothelial molecule involved in transmigration of cells in response to inflammation is ICAM. It is ICAM. ICAM1, that is intercellular cell adhesion molecule 1, it is CD11/CD18. ICAM, it is CD11/CD18, and it plays a role in both adhesion as well as transmigration. It plays a role in both adhesion as well as transmigration, whereas VCAM, vascular cell adhesion molecule, plays a role only in adhesion. VCAM, that is vascular cell adhesion molecule, plays a role only in adhesion. So the answer is ICAM. It plays a role in transmigration of cells. Next. Question 134. Maximum endocapillary proliferation, it is seen in PSGN, post-streptococcal glomerulonephritis. We have seen this earlier on the question on PSGN. Endocapillary proliferation, it is the microscopic appearance. You very well know, we have discussed it earlier, PSGN, it is associated with hypocomplementemia, that is reduced C3 levels, starry sky immunofluorescence, subepithelial deposits. These deposits, they have a special name to it called as humps. Subepithelial deposits and humps. We have already seen this. Next, question 135. Question 135. Blood in vessels does not clot because vascular endothelium is smooth and is coated with glycocalyx. Smooth endothelium coated with glycocalyx. This is a factual question. It has a smooth endothelium and is coated with glycocalyx. Next, question 136. Vitamin K is involved in the post-translational modification of glutamate. This also you know, nothing to explain in this. Vitamin K. So what we can do is the vitamin K dependent coagulation factors. Vitamin K dependent coagulation factors. They are factors 2, 7, 9 and 10. The vitamin K dependent coagulation factors are factors 2, 7, 9 and 10. Next. Question 137. Which of the following is caused by a glucocerebrosidase deficiency? Koch's disease. 137. Glucocerebrosidase deficiency. It is associated with Koch's disease. We will be doing this in detail in biochemistry, the various enzymes, what they are deficient with and the diseases associated with them. Glucocerebrosidase deficiency, Koch's. Next, 138. Translocation 1517 is PML rara. Let us see few points with this. You very well know translocation 1517 seen in acute myeloid leukemia. And which special subtype of AML? M3, that is acute promyelocytic leukemia. Acute promyelocytic leukemia. M3, good prognosis, poor prognosis? Good prognosis. Good prognosis. Why? Because we have therapy against this. And what is the therapy against M3? ATRA, all trans retinoic acid. Therapy for M3? ATRA, all trans retinoic acid. Next point, most common cause of death. Most common cause of death in M3, DIC, disseminated intravascular coagulation. Most common cause of death in M3, DIC, disseminated intravascular coagulation. Next. Question 139. Role of P selectants. This again is extremely easy, that is rolling. Rolling, it takes place because of binding of sialyl Lewis X glycoprotein. Rolling it takes place because of binding of sialyl Lewis X glycoprotein, which is present on leukocytes. Binding of sialyl Lewis X glycoprotein present on leukocytes with selectins present on endothelial cells. So the question was role of P-selectin. It plays a role in rolling. Next, question 140. Question 140. In which of the following metaplasia, dysplasia, carcinoma, squamous cell carcinoma? Only in squamous cell carcinoma we first have metaplasia, that is because of smoking, vitamin A deficiencies, which progresses to dysplasia, which in turn goes to carcinoma. Next, question 141. Before we go to that, a minute.